heart. Okay, and how do doctors actually look for early signs of heart involvement in epilepsy? Is there anything that we can do to protect the heart and to maintain good health over time? And I will talk a little bit about the research that we're doing and future hopes for ongoing research and hopefully new discoveries. So this is just the inaugural issue that we put together on the concept of the epileptic heart. It is the very first consortium of high sort of leaders in the field that outline the cardiac comorbidities and complications related to epilepsy. And this is the first time that we've put together our leaders and research in the field into a single issue for people to learn about and to bring recognition to this entity. One of the articles in this special issue was put together by Dr. Richard Verrier and Dr. Stephen Schachter. Dr. Verrier is a cardiac physiologist who had been studying cardiac health and sudden cardiac death for over 3 decades. And Dr. Steve Schachter, whom you may know, is a leader in epilepsy research and was the past president of the American Epilepsy Society meeting. Um, so, um, so here in this summary, we can see that patients with chronic seizures and epilepsy are more likely to develop heart disease than those without. And I've outlined here a number of key events that we identify in the literature. So myocardial infarction, that just means a heart attack, cardiac arrest, various kinds of more significant cardiac arrhythmias like ventricular fibrillation, sudden cardiac death. Atrial fibrillation is more of a common phenomenon, heart failure, and ischemic heart disease. And as you can see, this data is really gathered from multiple large population-based studies across different continents in North America, in Europe. And when you look at from very large population-based perspective, there is a significant increase in odds for all of these various types of heart disease. Some are as high as 5.8 for cardiac arrest. So you can appreciate from this really important data that this is a key area of health and disease that we need to learn more about so that we can prevent these issues. So pathophysiologically, what happens? How does seizures actually end up causing heart injury over time? So this is kind of little complicated diagram, but we outlined the 3 major pathways for how seizures can cause injury. And it's really due to the fact that during a seizure, what we often see is decreased oxygenation, that's referred to as hypoxemia, and that can lead to ischemia or lack of oxygenation to the heart muscles. And of course, during the seizure, we see that the sympathetic nervous system is really stimulated. And we know that because the heart rates are high, the blood pressure is elevated, and the combination of this catecholamine surge with hypoxemia and myocardial ischemia can lead to these 3 different pathways. On the left here, you can see that there's an acute myocardial stunning that we can see through echocardiography. And over time, this can cause actually scarring. And what you're seeing in the middle picture is just a pathology slide. When we look under the microscope, we see that the heart muscle is scarred down. So that means the heart is not as flexible, the muscles are stiff, and that impairs the normal contraction and relaxation of the heart chambers. And then on the right side here, we have atherosclerosis, and that's just a pathway that causes vessel narrowing. And that's really important when we constrict the blood supply to the heart muscles through coronary artery disease. And when we combine the three different pathways, we end up seeing a picture of what we call cardiac electrical instability, which means that the heart is not conducting electrically in a normal fashion and doesn't recover in a normal fashion, and that leads to atrial and ventricular arrhythmias. And so what's the definition that we came up with? Our group decided to come up with a unified way to define this as a heart and coronary vasculature damaged by chronic epilepsy as a result of repeated surges in catecholamines and hypoxemia, leading both to mechanical and electrical dysfunction. And over time, the repeated seizures can really stress the heart to the point where it doesn't recover appropriately. And this is what leads to the increased risk of heart disease that we see earlier in those with epilepsy at around age 45 compared to the general population when we start to see heart disease around age 55. So that's about a 10-year difference between those with and without seizures. And in this diagram, we really try to conceptualize the difference between SUDEP, which some of you may know is called sudden unexpected death in epilepsy, versus sudden cardiac death. And according to the CDC, SUDEP affects about 3,600 people per year, tends to be in the younger age group, age 20 to 45. But in sudden cardiac death, it's actually 4 times that number, about 16,000 people per year, and has a predilection for slightly older population. And these risks are a function of time. As people get older, the natural process of aging and progression of heart disease and epilepsy predisposes people to a high risk for both SUDEP and sudden cardiac death. And then on the bottom right, I just want to point out that some of the medications that we give to treat seizures and to control epilepsy can sometimes have unintended consequences. So while there might be helpful in reducing seizures, the older medications that can affect liver enzyme activity can cause lipids or cholesterol in the system to be elevated. And it can also make cholesterol lowering medications less effective because of that enzymatic induction. And then at the same time, through the mechanism of sodium channel blocking, which is one of the main methods that these seizure medications work, that can sometimes affect heart conduction because the sodium channels are common in the brain and the heart. And so sometimes unintentionally, when we give high doses of medications, that can cause heart conduction problems. And how do we detect heart risk then in epilepsy? And we've been able to do this by using some really novel markers that Dr. Verrier developed in his lab. As I mentioned, he dedicated over 3 decades to studying sudden cardiac death and has come up with some new analytic techniques. So I'll share that with you. One of those markers is called T-wave alternans. And has been shown to be correlated with someone's risk for a sudden cardiac death. And here, what I wanted to show here is just that, I don't know if you can see my cursor here, in the regular EKG, this is called a T-wave, and in T-wave alternans, it shows that there's a splay in the T-waves, meaning that from beat to beat, the T-waves are not overlapping perfectly. So the T-waves seem to have some slightly taller ones, slightly shorter ones. And so when we see that splay, that means there's something happening with the repolarization of the heart. With each beat is not recovering the same rate, and that is a substrate for causing potentially arrhythmia. And so this is an example of a recording that was made from somebody that we knew had coronary artery disease that's died suddenly after a year after this recording. And you can see that the yellow line and the white line, they just don't match up. And that's not a good sign that the heart muscle is repolarizing at different rates. And so this T-wave alternans seems to help us to identify cardiac risk in people with heart disease. And so this is what we call a ladder of risk. And on the bottom across, you can see that there are various heart pathologies that we've listed. And the threshold for abnormality for alternans is 47 microvolts. We have that in a dotted red line going across the screen here. And then you can see that in people with very stable coronary artery disease, the alternans level is low, not really close to the 47 microvolt. But as we march across the right, we see that people with cardiomyopathy, MI, and ST elevation MI have levels of alternans that are above the 47 microvolts. And then the one that I really want to draw attention is the drug-resistant epilepsy group. So that is actually quite elevated, and it's actually elevated to the point where it's comparable head and shoulders with people with ST elevation MI and ventricular tachycardia. Ventricular tachycardia is a very bad rhythm for people if we can't resuscitate them in time. And so alternans was one marker. Another marker that we use is called EKG heterogeneity, and it's somewhat similar to alternans. It's still measuring how each QRS complex in the EKG may differ from each other. So I talked about the T wave, and here instead of measuring from beat to beat, we measure the adjacent leads. When we do a 12-lead EKG, there are various different channels, and when we try to overlap the different channels, that's what is pictured here in the different colors. You can see that here again in the T waves, there is heterogeneity in that they don't match up perfectly. And so we can look at how much splay there is in the T wave, in the R wave, and also in the P wave that's not shown perfectly here. So the short of it is that the greater the splay, the higher the risk. And this is an example to show someone who has very abnormal T-wave heterogeneity when we measure the chest leads from V4 to V6. And I mentioned the P wave, that's in the atria, and that seems to also show some differences. And here you can see this is a measurement from someone where the P waves really don't match up very well just before the QRS complex. And it's been shown that people who have this particular arrhythmia called atrial fibrillation, the P wave heterogeneity is elevated in those people. And we know that atrial fibrillation is a bad rhythm because that increases the risk for stroke and also for symptomatic chest pain and all kinds of heart symptoms. So there is a double sort of bidirectional relationship. So epilepsy and heart health interfere with each other and they affect each other. And on the left-hand side column here, I've listed how epilepsy can affect the heart, and then conversely on the right, how the heart could affect someone's neurologic health. So on the left-hand side, there are many more things that I've listed here. So during seizures acutely, you can see that the heart rate goes up, and rarely the heart rate can actually even go down. That's called bradycardia. And asystole means the heart pauses transiently. And over time, heart problems can manifest in what we call prolonged QTC. The P, T, and R wave dispersion abnormalities measured by heterogeneity. And then we can also see autonomic imbalance. And that's just the balance between your parasympathetic versus your sympathetic nervous system. And when there is a loss of the normal balance, that can set up a substrate for heart arrhythmias, hyperlipidemia, and reduced heart rate variability, which is a measure of how well your heart can recover from exercise or stress. And then over time, we can also see some structural changes. The structural changes are things that we can detect on a cardiac echo. On the right-hand side, we know that heart disease is also associated with risks from a neurologic perspective. So for someone with irregular heartbeats like atrial fibrillation, that can increase the risk for stroke. And we know that stroke is a risk factor for epilepsy. And also actually genetic changes or abnormalities in ion channelopathies. These are just the way that the ions kind of flow across the cell membrane. And sometimes these genetic abnormalities can manifest both with cardiac arrhythmias and with epilepsy. So understanding that relationship is important in helping us to come up with the right diagnosis. And I wanted to mention just exactly what is SUDEP as well. Some of you may have heard that term, some of you may be much more familiar, but it is something that we work really hard to educate our patients and families about because it causes it's really the cause is unclear at this point, but what we know is that unfortunately, some patients succumb to sudden, unexpected death in epilepsy. And there's a landmark paper called the Mortimus study. In that particular study across various different continents in the epilepsy monitoring unit, what we observed was that almost in all of the cases, patients had a big tonic-clonic seizure that caused them to stop breathing, and that in turn caused the heart to stop, and that's what led to what we call now SUDEP. And what I'm talking about tonight in terms of cardiac arrest is a little different still from SUDEP. I showed you that Venn diagram earlier that SUDEP affects about 3,600 people per year and tends to affect the younger population, slightly younger age group 20 to 40. And we know that these are associated with the number one predictor is actually having generalized tonic-clonic seizures. And of course, if people are not consistent with their medications or the medications don't work well, then having repeated seizures really increases the odds for developing SUDEP. And then other risk factors include the male sex, and oftentimes patients are found in bed at the time with facing down. So we think that particular environmental factor can increase someone's risk. But as I mentioned, the main mechanism is the breathing that stops first that causes the heart to stop. Now, on the right-hand side, we want to compare what's the mechanism leading to sudden cardiac death. That's really because of just the run-of-the-mill cardiac disease, as well as coronary artery disease, and it tends to affect people that are slightly older, but the main mechanism is a primary cardiac arrhythmia and not really as a consequence of a breathing problem. In our group, we decided to actually understand whether this cardiac electrical instability in epilepsy is something that happens over time. And so the way to study that was to compare people who were just newly diagnosed, who may have had just 1 or 2 seizures in their lifetime, compared to people who have had the diagnosis for a long time and who have had years of uncontrolled seizures. And what we saw in this graph is that at baseline, when we measure their T-wave alternans, that novel marker that I talked about, at baseline, they don't look too different between the two groups. But as you can see in the newly diagnosed group, when we stimulate them, when we check their maximum level for the day, it's well below the 47 microvolts, whereas for people that have had epilepsy for a while, their maximum alternans level is well above, and that confers an increased risk. And that is one of the mechanisms that we propose in terms of why patients may be more susceptible to sudden cardiac death, and this might be a marker that helps us to identify who might be at increased risk. I wanted to show here one of the patients that we monitored in the hospital here in the epilepsy monitoring unit at Beth Israel. You can see that the alternans level here in the graph on the left is fairly low. And then all of a sudden on the fourth day, there's a sudden spike in the alternans level. And interestingly, right after that spike, we saw that the patient developed 5 beats of ventricular tachycardia, which we consider to be a dangerous rhythm. And this happened in my patient who we didn't know had any known cardiac disease. Now, we did know that she had uncontrolled generalized seizures, so we were able to give this information to her, and I recommended for her to see a cardiologist to make sure that she had a thorough cardiac evaluation. And in rare instances, we can actually capture the moment when a seizure can cause a bad heart rhythm, a malignant arrhythmia. And this is a case that was published of a patient who was admitted to the EMU at the Brigham Hospital. In the EEG here, we always record brain waves together with the cardiac rhythm. And at the tail end of this temporal seizure, you can see that a regular heartbeat kind of degenerated into ventricular tachycardia. And fortunately, because the patient was in the hospital, timely resuscitation was given and the patient had a good outcome. But you could imagine that if this happened at home without the concurrent careful monitoring, sometimes we may not be so successful in capturing this in time and delivering the therapy that's really needed in a timely manner. This is another example that was published in the literature of someone who had a seizure, and during the seizure developed going from kind of a bradycardic rhythm into a very irregular cardiac rhythm. And in this particular case, this is called atrial fibrillation. And this is really just fortunate in terms of the recording that we were able to capture this in real time. So, so in some of the features of the epileptic heart, we can actually get a sense or get a gauge just by doing a regular standard 12-lead EKG. So some of you may know that when you go to get your annual physical or you go and see your regular heart doctor, they may just do a quick 30-second recording, a 10-second recording. And in this recording, we can see that various components can tell us about risk. So the P wave can tell us about atrial fibrillation, which is present in up to 10% of patients. The ST segment is an indicator of ischemia. Either elevation or depression can tell us that perfusion to the heart muscle is inadequate, and this could happen in up to 40% of seizures. Q waves is a sign of silent heart attacks. So sometimes people don't necessarily have symptoms right away and they recover, but the Q wave is a signature that something has happened before. And in the European Stockholm study, we know that the risk for myocardial infarction is increased by 4.8-fold compared to the general population. And then finally, the QT interval is a very standard measure that the FDA uses when they test for new medications. It tells us about how the heart conduction recovers after a QRS complex. So if there is abnormalities that I showed in the T-wave alternans or the heterogeneity, that predisposes patients to ventricular arrhythmias. And in up to 1/3 of patients can show abnormalities in the QT interval or dispersion. So how can we tell if something is happening with the cardiac rhythm? Well, there are some ways that we can actually monitor patients using long-term ambulatory patch monitors without wires. So these patch monitors that you can see are some FDA-approved devices that the cardiac doctors use. The first one is called a Zio patch. It's a single channel. and that is something that we use commonly to monitor for atrial fibrillation. And this particular monitor allows us to measure what's called the T-wave alternans. On the bottom diagram here, the picture here is called a MyPatch monitor. This is actually what I use in our current studies. It offers 3 channels and allows us to measure both alternans and heterogeneity. And with those measurements, we can actually try to come up with a risk stratification mechanism. And in addition to measuring alternans and heterogeneity, other things that we can tell with the patches would be really rare and short, brief signatures of potentially arrhythmia. So some examples here would be episodic atrial fibrillation, ventricular premature beats, which are not considered dangerous unless you have a lot of them. Non-sustained ventricular tachycardia, similar to the example that I showed you, my patient on the 4th day of her monitoring. And then some of the other events that we consider to be arrhythmias that we see during the seizure. It's called ictal pro-SCD events. Excuse me. So sometimes you may have a cardiac tachyarrhythmia, meaning the heart rate is elevated, ST segment changes, and then T-wave alternans and heterogeneity. So in addition to kind of just conduction, we can tell about the function of the heart. Excuse me, let me get a drink of water. In the cardiac echo, we can get a gauge for how the heart pumps and how the heart relaxes. So when the heart doesn't relax properly, it's called diastolic dysfunction, and that's what's caused by the fibrosis and stiffening. We can measure that by, doctors that specialize in echocardiography. And then sometimes that can cause the heart to become dilated. So that's what's called increased left atrial volume. That can set the stage for atrial fibrillation. And these changes are called pathophysiologic changes that can be mediated because of the catecholamine surge during seizures that can lead to, over time, myofilament damage or damage to the microfibers of the heart muscle. And that over time causes inflammation and fibrosis. So I'm going to pause here for a second because I do see some chat. I just want to check and see if there are any questions in the chat.
There are. I'm happy to read them if that is helpful.
Yeah, that would be great. It's
Okay.
really small on my screen.
Yes, no worries. So the first one is from Robin. She said, just curious, you mentioned how many anticonvulsants can create difficulty in cardiac stability, normalcy. Is there a way that neurologists can measure that or see it happening? Should we be getting EKGs more often to measure better?
Yeah. So actually that's in part of the concluding slides. There is a way to see whether an anticonvulsant is causing some issues in the cardiac conduction. And typically when we see someone in the initial early stages of diagnosis, I always get like a baseline EKG to measure for comparison. And then later when we make changes to their medications, if we know that this is a medication can cause problems, or if we're using combination of medications that can cause problems, this is when we actually try to repeat the EKGs in regular intervals to make sure that we're monitoring over time.
Wonderful. Next question said from Alana. Also, what role does, I'm going to probably troponin play in seizures?
Yeah, so troponin is something that we measure acutely if someone's having a heart attack. So if you come to the emergency room and you're telling the doctors you have chest pain, they do the blood work and they can measure troponin. So troponin, the regular troponin that's measured in the emergency room is not as sensitive for detecting heart damage let's say, right after a big convulsive seizure. But in the literature, in the study group from Germany, they've been able to show that really high sensitivity troponin can detect acute damages to the heart muscle, but it's not something that is measured, that is, gathered in a routine blood work. But that particular study was really instrumental in helping us to understand that, hey, the heart muscle does get damaged, and here's the evidence.
Absolutely. Amara said, "Does when you start having seizures affect epilepsy heart issues? So when does it?" And her first seizure was in 2019. So when does it start impacting the heart?
Yeah, that's a really great question that we are still working on and researching. We don't have the exact answer, but we know that if you had, first seizure in 2019, but if you got your seizures under good control, you are not accumulating, additional insult. But if the seizures are difficult to control and you continue to have seizures, especially the convulsive kind, where that causes the greatest disruption to your blood pressure and your heart rate, that seems to have the greatest effect on your heart health. So I think over time, that's what we try to show, that people with chronic epilepsy did show those abnormalities in the Alternance numbers. And so we hope to be able to do more research to understand how long, or how many seizures, or what are the factors that could lead to this development. And then the question is, how can we prevent people from getting there?
Absolutely. The next question was, does Dandy Walker syndrome impact epilepsy and heart failure?
So I'm not a pediatric epileptologist, and I don't actually treat people with Danny-Walker syndrome often at all. So I know that people with Danny-Walker syndrome can develop epilepsy, and it's really kind of like the same mechanism. So if they happen to have seizures and the seizures are difficult to control, this over time can lead to heart failure.
Okay. Gina, so the anti seizure medications themselves can put someone at increased risk for oh, those little emojis came up, risk for one of these heart diseases as well as occurrences of tonic-clonic seizures.
So I'll say that some of the anti-seizure medications can do that, and I have some slides later on that will touch on that. The older generation and the enzyme inducers, the really strong sodium channel blockers, can all affect someone's heart disease risk. And so that's what we're trying to balance, trying to control the seizures versus the medications that we give.
Okay, we just have a couple more. How does sleep apnea affect SCD, SUDEP, and electrical instability in people over 50?
Yeah, what a great question. And that's really complicated. So, from our current understanding, and we're trying to understand the relationship between all three. First of all, sleep apnea is considered a risk factor for heart disease in general, because it can cause pulmonary hypertension, it can cause increased strain. And so, from a heart health perspective, we want to get the sleep apnea treated. Does sleep apnea contribute to SUDEP? I don't think that we have necessarily definitive data to show that just yet. Um, we certainly know that sleep apnea can affect heart health, and if you have seizures that are poorly controlled, that's kind of a double whammy. And so my recommendation would be first to up both at the same time in parallel, treat the sleep apnea and really optimize the seizure control to try to minimize the risk for both SUDEP and for sudden cardiac death.
Absolutely. Is elevated blood pressure reading a good warning sign?
So, we see, elevated blood pressure quite commonly in the general population as people get older. That seems to be something that people develop. Um, so I think that we
Is there a
understand.
difference in risk?
Well, make sure everybody's mute button is on. That would be wonderful. Thank you. Sorry.
Yes. So actually, so high blood pressure or hypertension can contribute to atherosclerosis. And as you recall, you may recall in the earlier slide, atherosclerosis is the process by which we know contributes to the epileptic heart. Because that can cause coronary artery narrowing, hypoxia, or cardiac ischemia during seizures. So that's, the indirect way of how hypertension can potentially worsen someone's risk for the epileptic heart and heart health issues.
Wonderful. We have one more, and I'm probably going to say this wrong. Laura had said Jeavon, Jeavon, and heart disease risk.
Um, so is it, I'm trying to find that question. Is it Jevons?
Laura Martins, Jevon, yeah, and heart
Oh,
disease
oh,
risk.
oh, yes, I see it. Okay, so in Jevon syndrome, I think from my limited interaction, because most of the people with Jevons actually are treated in the Children's Hospital, most of those patients actually have myoclonic seizures and absence seizures. And so those, in our opinion, are likely, we don't know for sure, but are likely less problematic than the big convulsive seizures. And so that is something that we still need to pay attention to, because sometimes seizures can affect your autonomic nervous system without necessarily causing your entire body to be jerking sort of violently. So that is something that we need to study more, understand more.
Absolutely. Dr. Pang, we can let you finish, and then we can just also continue at the end if we with the rest of the questions.
Sure. Yeah.
Okay.
Okay, let's advance to the next slide. Okay, so I just wanted to show an example here in the literature of how an acute seizure can cause ventricular tachycardia. So this is an example of someone who had a big convulsive seizure at home, then had another one in the emergency room. And because they were in the emergency room being monitored, they captured this run of ventricular tachycardia. So the heart is really not pumping effectively. And when they did further studies to look at what was happening, they did an echocardiogram, and they found that the ejection fraction, which is how efficiently your heart can pump, was really way down on admission. So this was right after the seizure, where the seizure caused what it's called myocardial stunning. So it kind of stimulated the heart so much that it made it less effective, and the ejection fraction went down to 30%. Fortunately for this person, over the next 4 days, the heart was able to recover, and the ejection fraction came back up to 55, which is a much better number. But you could imagine that if you kept having generalized tonic-clonic seizures, that ejection fraction may not recover so fully over time. And so to bring more visibility and understanding and recognition to the epileptic heart, our group put together a set of criteria. We call it the syndromic criteria. So this is to help people to think of it kind of in a group of symptoms, just like metabolic syndrome. So in this set of criteria, we included, of course, having chronic epilepsy with or without drug resistance, and any evidence of arrhythmic risk or myocardial injury on their standard 12-lead EKG. Q waves, QRS complexes that are widened, QT prolongation, ST segment elevation or depression, and alternance levels that are elevated. And if there's any evidence on echocardiography that there is diastolic dysfunction, heart's not relaxing properly, and so the heart is stiff and is not able to accommodate the blood flow or return in between the beats. And we know from the literature that the autonomic balance can be really disturbed in people who have poorly controlled seizures. And one of the ways to measure that is by looking at heart rate variability. And that's something that you might have seen in your Apple Watch or your Fitbit. And the thing that people measure in the literature is called RMSSD. So when you get a very low RMSSD, that's a measure of poor vagal tone or poor relaxation in the autonomic nervous system. And then finally, we talked about the issue of atherosclerosis and hyperlipidemia. Some of the patients who are on the older generation medications that can really affect LDL and HDL levels. So we want to make sure that we check those. And we know that the hyperlipidemia can contribute to metabolic syndrome. So we want to make sure that we are monitoring appropriately over time. And in addition to the lipid story, sometimes seizure medications I mentioned can actually generate higher risk for cardiac arrhythmias. And the classic medication class that we talk about are called sodium channel blockers. These are really great for blocking seizures, but if we use high doses or in combination, that can cause cardiac arrhythmias. And in the older generation of anti-seizure medications that have been reported in the literature are carbamazepine and phenytoin. And so the relative risk can be increased by 3.2-fold or twofold with phenytoin. And so we want to be really, really careful when we're selecting medications for people who are known to have heart disease or people who we suspect might be at higher risk for heart disease. And so I wanted to just bring some clinical context here. This is a clinical case of someone that is in my clinic that I take care of. This gentleman had seizures for a very long time, and this is his combination of anti-seizure medications. He takes lamotrigine, lacosamide, and levetiracetam. And we wanted to bring him into the hospital to record some of his typical seizures to see if there's anything else we could offer in terms of treatment. And during his seizure recording, we noticed that when he first came, his heart rate was low. It's called bradycardia. And when he was sleeping, his heart rate was really low. It went down to 40. And this was not something that he was aware of or reported to us. And what I wanted to show here, it's a little bit busy, but during one of the seizures, it caused his heart rate to go down. And I don't know if you're able to see in the numbers here, but like the heart rate went down from somewhere in the 80s down to 30. And then here at the end of the slide here, you notice that the EKG doesn't show any additional signal. That's when the heart kind of paused very briefly, and that is something that is very concerning to us. This is called ictal asystole. The heart transiently pauses, and but fortunately, the good thing is that the heart does recover, and sometimes it can vary, from person to person how long the heart pauses, but it just shows that the seizures can be quite varied. And with the interplay between seizures and medications, we have to be cognizant of how the heart is responding to both. And this always raises a question when someone kind of loses consciousness. Is that because they had a seizure, or is that because they had a fainting spell, which we call syncope? And so the two entities do overlap. So when patients pass out, this could be from a heart cause, and sometimes this could be caused by seizures, and that's where we have this overlap here called ictal asystole. And the way to really know that for sure is to be able to record the brain waves together with the heart rhythm, and together with the video, we put everything together, and that really helps us to come up with an accurate diagnosis. Now I want to talk about the cholesterol story. So epilepsy can predispose people to high cholesterol and hasten the process of atherosclerosis. In the bottom right is the picture of what atherosclerosis looks like. There's cholesterol that's built up on the interior side of the artery here, and the blood can't pass through very well. And so the way that cholesterol can cause problems in people with seizures over time is that sometimes, patients with epilepsy may not be as active as they would like. Maybe they're not eating as well or as healthy pattern as they would like. And then it's the medications. Sometimes the older generation, what we call the enzyme-inducing seizure medications, they can actually automatically cause the bad cholesterol to be elevated. So by bad cholesterol, we mean low density lipoprotein. So and then the other seizure medication, valproic acid, even though it's not an enzyme inducer, can contribute to metabolic syndrome by inducing appetite, weight gain, and that can also have bad reactions and contribute to the process of atherosclerosis. This is a recent population-based study in Canada where they wanted to look to try to measure how do anti-seizure medications contribute to cardiovascular risk in older people. And so what they did was they followed a huge number of people here, over 30,000 people over time, and they looked at three things: stroke, mini stroke, TIA, and myocardial infarction or heart attack. And they followed these people over a span of 6 years, and they found that people with epilepsy was associated with a 2.2-fold increase in odds of any new onset cardiovascular events that we talked about: stroke, TIA, or MI. And about 1/3 of this association can be explained by enzyme-inducing seizure medications. So here's another yet population-based study that helps us to really think hard about how we choose the anti-seizure medication regimen for our older patients who are at higher risk for heart disease to begin with. So I wanted to then summarize, what can we do about this? Is there anything that we should be thinking about even now as we're trying to understand this entity a bit better, trying to gather more data through studies? And I think there are a number of things that we can do for the older age group, people that are 45 and older, who we know are in the higher risk group. We want to develop and educate about heart healthy habits, quitting smoking, controlling blood pressure, cholesterol, and diabetes. But from our perspective, choosing medication treatment regimens carefully is really important so that we don't increase the risk associated with high cholesterol, induce arrhythmia problems as much as possible. And whenever possible, we should always think about alternatives to valproate, because that can increase someone's BMI and contribute to metabolic syndrome. And then from a monitoring perspective, I do think it's really important that we check a baseline 12-lead EKG to get a sense for how things are before we start on someone on medications, and then to repeat that when we are using medicines that we know can cause rhythm abnormalities. Now, it is very important that we control seizures, but we are, balancing that seizure control with cardiac health at the same time. And if we see that maybe abnormal rhythms or there may be abnormal signatures, then that's when we want to consider doing some longer term monitoring with a Holter monitor or a patch monitor that I mentioned. These things can help us to identify rhythms that occur on a very rare basis. So sometimes people might need to wear the monitor for 10, 14 days to be able to tell if something that's indolent and asymptomatic might be occurring, and they're not aware. And if there's anything abnormal, or if you have a high index of suspicion, I would say that we should be working very closely with our cardiology colleagues to get a full assessment, to get a full sense of what's happening. And this holds true even for people who are in the younger age group, less than age 45. It's always never too early to develop heart healthy habits. The same sequence, in terms of controlling risk factors. And we also should be cognizant about choosing medications carefully, not inducing high cholesterol and not inducing rhythm problems as much as possible, and not contributing to higher BMI, and considering valproate alternatives whenever feasible. And same thing, getting baseline and then getting repeated monitoring over time, especially when we know we're using medications in combination that are at higher risk for maybe speeding up someone's heart or slowing down someone's heart or causing conduction delay. So if there's any concern about rhythm abnormalities, we should be working closely with cardiology for a full assessment. And in the younger age group, of course, this relates to the older patients as well, but we always want to think about SUDEP prevention because we know that that's something that's really important that affects our patient population. One exciting aspect of the work that we're doing is specific signatures that we have been noticing in our epilepsy monitoring unit. In this particular case, we saw that in patients who had generalized tonic-clonic seizures, we were able to see an elevation in their T-wave heterogeneity well before the actual onset of the seizure, up to 30 minutes. And the red line is people with generalized tonic-clonic seizures. We see that there's this gradual elevation in T-wave heterogeneity versus people who had non-epileptic events. Maybe they were having headache or maybe a fainting spell from a different cause. We didn't see that signature in people without epilepsy. And so we thought, well, we could potentially study this particular marker to help us to forecast when a seizure is about to happen, not when someone is already in the midst of a seizure and there's not much we can do at that point. So I wanted to really give special thanks to the Epilepsy Foundation New England for actually giving us the support to be able to study this particular issue. And we are in the thick of analyzing our data, and we hope to be able to share that fairly soon. So there is much to be done in this area. We need to understand the sensitivity and specificity of these cardiac markers that I talked about in predicting an impending seizure, whether that's a focal or generalized seizure. We also need to study, understand the role of anti-seizure medications, especially the sodium channel blockers, on these particular markers that I talked about. We are also in the process of analyzing our data to see how medications can affect T-wave alternans and heterogeneity. And then someone asked that great question about the prevalence and extent of biomarker abnormalities in patients. When do we develop these abnormalities? When do we see people developing signs of the epileptic heart? And then finally, these are the most important questions, is how do we reduce risk? Are there things that we can do in a treatment realm to reduce risk? So I talked about, choosing a seizure medication regimen really carefully. Can we modulate the autonomic nervous system? We know that the vagus nerve stimulator can modulate the autonomic nervous system. Can we mitigate risk that way? And then we have the typical antihypertensive drugs in the beta blocking category. Can we block the catecholamine surge during seizures to protect the heart in a sense that if we know someone has a lot of these, can we prevent heart injury over time? So the final take-home messages are that we think that drug-resistant epilepsy may predispose people to the epileptic heart syndrome, a risk that increases with age, especially for those who are in the older age group, and may increase their risk for sudden cardiac death by up to 2.8-fold. And we want to bring recognition to this entity by using the syndromic approach and integrating various diagnostic tools that we have in our toolbox. And that includes using the EKG markers, measuring autonomic balance, using echocardiography to look for myocardial function, and really monitoring lipid profiles. And epilepsy management should really take on really individualized strategies in both optimizing seizure control, but also identifying and monitoring and managing cardiovascular risk factors. And I think working closely with our cardiology colleagues is very important for us to come up with a multidisciplinary care plan that is all comprehensive in terms of monitoring and intervention. And something that we're working really hard towards is further research to come up with better monitoring and preventative strategies to help our patients. So I want to give special thanks to all of my collaborators, Dr. Richard Verrier, Dr. Bruce Nearing, who's the engineer, Dr. Schachter, a leader in epilepsy research, Sandra Verrier, who helped with our studies. Special thanks to the Shearer family, the Neurology Department, and Epilepsy Foundation New England for supporting the important work that we're doing, and the fellows and patients who have volunteered their time to make this work possible. So now I'm ready for more questions. Thank you so much.
Thank you so much, Dr. Pang. So we do have a few more that are coming through the chat. There's one from Alana again. Does low ejection fraction come from seizures?
um, excuse me. It can. So we talked about myocardial stunning. So that's what causes the low ejection fraction acutely after a big tonic-clonic seizure. Excuse me. And if the myocardium gets injured enough, it may not pump effectively, and so that could cause a low ejection fraction. And the way that seizures causes is really from the acute seizures. Excuse me, just recovering.
No, no, you're fine. Um, then we talked about the vagus nerve stimulator already. What if the seizures cause a high heart rate of above 200, then dramatically drop quickly to the low 60s? Would you be concerned, and should I be more advocating for this?
Okay. So it's typical actually to see that a seizure can cause high heart rate. When the heart rate comes down, that's a sign that the process of the seizure is likely resolving and the heart is recovering from that whole process. It's generally not a problem. 60s is considered a normal heart rate. If you're starting to see heart rates that are well below 60, so in the example I gave, like, 50 or 40, those are really pretty low heart rates. Unless you know that person normally lives in that range, we might be a little concerned that that's too low. So it's knowing what's the normal for that person and understanding what you're observing, how that relates to what their normal baseline.
Great. I actually got an email actually before tonight's webinar with actually a question that came through. Our son Noah is 27 and was born with trisomy 21 and diagnosed with autism at 20 months. He had his first seizure out of the blue January 2022. His neurologist prescribed an entry-level dose of Keppra and a rescue nasal spray Valtoco. After his second seizure, September 2025, we found a low heart rate of 30 beats per minute and the data of a Zio heart monitor he wore for 2 weeks. She is concerned that he may have a Wenckebach block.
Oh, okay.
We have a referral to a cardiologist for March 19th. What are the questions or further tests, and what should we be aware of?
Okay. That's a really complicated scenario. I think number one is to get the full evaluation from the cardiologist. Understanding why the heart rate is so low is going to be key to knowing what happened. So the Wenckebach box sometimes is kind of a genetic abnormality. So that's something that you definitely need to bring up to the cardiologist and to the neurologist as well. Is there a link between the two? Because we know that there are genes that can cause heart arrhythmia and epilepsy. And so, that becomes an issue when we're treating seizures. We don't want to give medications that could cause further heart block and cause further bradycardia. And then likewise, when you're treating the heart, you don't want to give a stimulant that could make your seizures worse. So having a really close dialogue between your heart doctor and your neurologist is really important.
Just writing that down for them in case they weren't able to make it tonight.
Okay.
Awesome. Thank you so much. The other questions we have is we talked about that, but keto an adult risk factor for heart data.
Yes. So the the true ketogenic diet is really high in fat. And so we don't think that's a great thing for cardiac health over time. However, the keto diet in the short-term use has been shown, at least in the pediatric population, to be really helpful in controlling seizures, especially in kids that just are refractory to all different kinds of medications. The good news in some of these kids is that they're able to actually maintain some of the seizure control even after coming off the keto diet. I have some of my colleagues at Boston Children's who monitor these kids carefully. And sometimes they have kids that are able to maintain it for a longer period of time. But I do think that in the older adult population that are already susceptible to hyperlipidemia, coronary artery disease, hypertension, diabetes, the risk is not so simple just from high fat. And I do think that needs to be taken into consideration. So having a full cardiac risk factor profile and understanding, where your heart health sits before you start a keto diet is really important.
Other question, any advantage of extended release versus non-extended release Keppra? Both seizure control and cardiac risk.
Okay. As far as we can tell, we don't think that Keppra affects cardiac rhythm abnormally or affects lipids abnormally. So extended release or not extended release, I think in my mind doesn't make a huge difference. It's just based on tolerability.
Absolutely. And then another question said, how can we participate in your research?
So right now our research is primarily based on inpatients who are admitted to the epilepsy monitoring unit because that's a really safe environment when we can record seizures and record their heart cardiac rhythm. So that's the main method. We have in the past done monitoring on outpatients as well. So if there is a specific concern from that perspective, we could potentially do ambulatory monitoring in the outpatient setting. And our protocol right now is mainly based on inpatients, but hopefully we are, well, we're hoping to get additional support that allows us to do outpatient monitoring concurrently with the inpatient monitoring.
Absolutely. And I'm going to take just one more question because I know your time, Dr. Pang, is so very important. Are there known significant effects of CBD on the heart?
Oh, I have to say we don't know enough about it yet. That is to be discovered and understood over time.
Absolutely. Well, I want to say thank you so much for being here tonight and allowing us to have you and spend your time. I always remind everybody that our doctors that come on our Wednesday webinars are sharing their personal time with us. So thank you so much for volunteering to be with us, Dr. Payne, tonight and sharing this important information. We will be sharing the recording of the YouTube with everybody. So you will be getting the recording as well, and it'll be, like I said, on our YouTube channel. There were questions about your slides and being able to share those with the participants. Is that something that you'd be willing to do and having allowed to have those slides shared with, or is that something that
Not
is
a
something?
problem. I think
Okay,
probably the easiest is if I send a copy to you, Christine, and then you
absolutely,
could disseminate to
absolutely,
people who are interested.
absolutely.
Yeah.
All right. Well, thank you so much, Dr. Pang, and I look forward to seeing you again soon. And thank you so much for everything you do for our families.
Thank you so much for the opportunity, and I want to wish everyone a good night.
Thank you so much. Have a great night, everybody, and see you guys soon.